All right, the fifth lecture in the cardiovascular system is about the cardiac conduction system, actually what makes your ticker tick, and about the fatal arrhythmias or the heart arrhythmias. The topics include the conduction system, and the goal, of course, is to keep everything with coordinated contractions. And we're going to go through all of these different pathways, starting with this sinus node that's right here at the, looks like where the inferior vena cava and superior vena cava come into the right atrium. And then spreading to, of course, the AV node and then the rest of the conduction system. Of course, the whole goal is to make sure everything is perfectly coordinated. So that first firing from the sinoatrial node sends the impulse to the left atrium. So both atria contract at the same time. And then the impulse goes to the AV node. And the AV node goes into the bundle of His and then separates into left and right bundles that are located in the interventricular septum. And then those fire off at the same time so that both ventricles contract at the same time. Now the Purkinje fibers are down deeper into the myocardium. And then, as we'll see in a minute, the final end is the intercalated discs. Those are discs within the cells of the atrium, and in the myocardium. So the pathways: one, AV node. Number one, SA node. Number two, the atrioventricular node. Bundle of His, left and right bundles, and the Purkinje fibers. And if you want to remember, there's a mnemonic called this: if a patient's family were all having heart attacks, you must save his bundle of kin. So SA node, AV node, bundle of His, and Purkinje fibers as kin, KIN. Now, to get a really good look about how the heart is functioning, looking from the inside, you can look through this app called Visible Body, showing the conduction system, and the blue denoting the deoxygenated blood, and red is the oxygenated blood. And to find these animations, you can go under My Apps in courseware, and then go under Physiology Animations. And then within that, you'll pick the heart. But all of these others are great animations. And like I said before, the intercalated discs are within the muscle cells themselves. So beyond the Purkinje fibers are these intercalated discs. So they coordinate each cells to contract. First question. MI, myocardial infarction, otherwise known as a heart attack, is a lack of oxygen to cardiac muscle cells. What will happen to your conduction system? A, no change in heart rhythm, or B, a disruption of normal conduction, which is known as arrhythmia. And of course, the answer, disruption of your normal conduction system. So knowing that ahead of time, you'll always want to be prepared. If you suspect anybody might be having a heart attack, is to prepare for defibrillation and CPR or life support. So the first case scenario, a 78-year-old woman in the emergency room comes in complaining of indigestion. The ER physician runs a test at the bedside that confirms she is indeed having a heart attack. What bedside test did he do that told him right at the bedside the patient was having a heart attack versus just having a heartburn or angina? So she's actually killing heart muscle at that moment. Did he do a chest x-ray? Did he do an upper endoscopy, which is a upper GI looking into the stomach, or an EKG or electrocardiogram? The answer is an EKG. This is looking at the coronary arteries, and the EKG can tell not only what's going on in the conduction system, but it also shows if there's areas that are ischemic or areas that are acutely dying. The muscles are dying. So this is an EKG, a QRS, the normal showing the different waves patterns that come across the electrocardiogram, where Q is the beginning of the ventricular contraction, QRS. So this is the ventricle. This is the AV node. This is the atria. In an acute MI, it's called a J point, but you'll see ST elevations. So before the T wave, it'll become acutely elevated. Whereas someone having angina, they'll have inverted T waves. And an old heart attack, scar tissue, would show as this depressed Q wave. So that's what's so great about the electrocardiogram, is it shows what's going on in the heart and how the pathways are running through the heart muscle. So you can tell if someone's had an MI in the past, they're starting to have an MI, if they have arrhythmias, and also you can tell if they're having electrolyte abnormalities. And the example I'm giving there is potassium. One way you can tell with potassium is you'll get these peak T waves, these big peak T waves with high levels of potassium. And also they'll show drug toxicities will show up in the EKG. You can see tricyclics will have normal EKGs, as well as digitalis. It's called the dig effect. So notice that the impulse begins at the SA node, the sinoatrial node, and it doesn't go straight to the AV node. First, it goes over to the left atrium, because both atrium need to contract at the same time. So the P wave is the contraction, or the impulse traveling through the atria, and then the QRS is the impulse traveling through the intraventricular septum and the walls of both the left and right ventricles. This is just showing a still photo of what you just saw in the video, where the P wave captures both atria, the QRS, the ventricles, and the T wave is repolarization of the ventricles. The P waves, the atria do have a repolarization, but the waveform gets hidden in the QRS complex. So you can find lots of things going on in the heart by looking at the EKG. This is a case of a patient comes in increasing fatigue. The EKG shows widened P waves right here. So normally you should just see one single P wave, and this is called P mitrale, or widened P wave. So based on his heart, what part of his heart is abnormal based on this EKG? Is it the problem with his ventricles or the problem with his atria? The answer is it's the atria, because it's taking a long time for that electrical impulse to go through both atria. So at least one of his atria is dilated. And this is seen in mitral valve regurgitation. Slowly over time, the atria gets wider and wider, bigger and bigger, because the mitral valve is not allowing all the blood to go forward. And so it just slowly distends this left atrium. And eventually what will happen is blood flow will start backing up into the lungs, and the patient will start developing pulmonary edema. So this is normal on the left, and these are the numbers you see here are the pressures that are within the left ventricle and left atrium. So over time, this extra pressure increases in the left atrium and distends it. This is mitral regurgitation. So more clues, another case scenario to look at the EKG. Patient has a heart attack. The doctor looks at the EKG and says there is a blockage in the left anterior descending artery. So the left anterior descending artery feeds the intraventricular septum. If blocked, what part of the conduction system would be affected? Would it be the SA node, the atrioventricular node, or the bundle branches? The answer is those bundle branches right here. These are the bundle branches. With a bundle branch block, you'll start to see widening of the QRS. Okay, so let's go on to arrhythmias, abnormal heart rhythms. So normally, normal sinus rhythm is a regular rate, regular rhythm, shown on top. And this AVF is the name of the lead, because the heart leads can go across the chest, so you'll get different waveforms. And then steady rhythm here by the QRS shows that they're not equally spaced. So let's do a case scenario. Your 80-year-old grandmother gets very dizzy when she stands up. You feel her pulse after she has a spell. Her pulse is very slow at 40 beats per minute. And this is her EKG. This is lead 1 and this is lead 2. What part of her conduction system has failed? Was that her sinus node, her atrioventricular node, or her bundle of His? And the answer is her SA node, or sinoatrial node. The great thing about the conduction system is that it has a backup. If the SA node fails, the atrioventricular node will take over, but it takes over at a much slower pace. So it'll take over at like 40 beats per minute. So she has what's called sick sinus syndrome. This is when the SA node fails. And the treatment for that is a pacemaker. Can either go into the atrium, but a lot of times they'll put it into the ventricle, and then it'll give that electrical signal at, like, usually it's around 60 beats per minute. So they can put in either atrial leads, ventricular leads, or both. If they put in both, it's a much more coordinated contraction and you have a better cardiac output. So a lot of times they like both. This EKG that's showing here, these are called pacemaker spikes. And that's the electrical activity you see when you're doing an EKG. And since the electrical spike is shown just before this QRS, you know that the pacemaker's been placed into the right ventricle. And the QRS is just a little widened, which means that the electrical impulse is coming from this area and going across from the right to the left. All right, another case presentation. This is a case of atrial flutter. It's when there's an extra focus of electrical activity in the atria, one of the atria. And it's flutter means it's coming from one location site usually, and it's firing off faster than the SA node. So it's taken over, essentially it's taken over from the SA node. And this is an actual case example of a patient I was taking care of that was coming for cardioversion. Atrial flutter has this sawtooth rhythm. Now this monitor is showing 2 leads right now. The top is the lead 2, bottom is ventricular lead 5, and you can see those P waves are this sawtooth constant pattern. That's one way to tell. And it can go much faster than 108. This patient had some medications that slowed that heart rate down, so it wasn't going quite so fast. The next waveform is the pulse oximeter. And then another is a blood pressure cuff, systolic and diastolic. And this was the end-tidal CO2. And this was before the CO2 monitor was placed. So the monitor was reading apnea. Atrial flutter is one of those unstable rhythms. So that is where patients need to come in and have what they call elective cardioversion. They get medications, just short-acting medications, so they fall asleep for a brief period of time. And so they wake up very quickly after. Now, the thing with any type of elective cardioversion, if the atria have been in this abnormal rhythm, is that they can develop blood clots in their atria because the atria aren't contracting well, and so blood can be swirling around and form blood clots. So before the cardioversion, the patient will have this transesophageal echocardiogram to look down and see if there's any blood clots in the atria. This is the probe that goes down, and it'll have a camera, a little camera lens on the end of it, and it'll look at the heart chambers. And it'll look at different views of the heart chambers. So the top view is one view, and this view is looking at the left atrium, left ventricle, and then looking at this area right here in the left atrium that collects clots. This bottom one is a 4-chamber view where you can see both ventricles, both atria. And of course, this is going to be the left ventricle because it's so much thicker. So this is the actual video of the patient that we were taking care of. And this view is showing the valve between the left atrium and the left ventricle. And then right in here, this left atrial appendage is where a clot can form. So next question, what is that heart valve between the left atrium and left ventricle? Answer is the mitral valve. Now the clot tends to form in this atrial appendage. They also call it the chicken wing. And with atrial flutter or atrial fibrillation, the blood tends to swirl. And if blood just is swirling and not moving forward well, and the heart is not contracting well, that blood clot can form in that left atrial appendage. And so that's what the cardiologist is looking for, is for clot. And the reason it's so concerning is that if that gets dislodged during the cardioversion, then the patient could have problems. So if they did have a clot there, what they would do rather than go ahead with the cardioversion is give the patient blood thinners to dissolve the clot prior to a cardioversion. So remembering the systemic flow of blood, if that clot dislodged from the left atrium, where would it land? Would it go to the lungs or would it go to the brain? The answer is it could go to the brain. It could also go to the legs, the GI tract, go to all of these places. So notice the flow of blood goes out the aorta and goes to the systemic circulation. It would not go backwards into the lungs. Okay, so that's just a video of actually doing the cardioversion for this patient who is in atrial flutter. And this is a lower voltage, but still the patient needs to be very heavily sedated, nearly pretty much asleep for this. I'm going to talk about the main rhythms that are very deadly, including ventricular tachycardia and also ventricular fibrillation. So atrial tachycardia is bad because it's, it's abnormal rhythm, it's unstable, but ventricular tachycardia is much worse because it has this abnormal focus and it's reducing your outflow, so blood pressure drops dramatically. Now this, I'm not even sure this is a human heart. This was a video I found showing what ventricular tachycardia looks like. So you can see it just uncoordinated, really, really fast. And so the blood pressure just doesn't generate good blood pressures. So in summary, the conduction pathways we've discussed, and EKGs and the heart arrhythmias. And the sequence going through were including the SA node, AV node, the bundle of His, the Purkinje fibers, and lastly, those intercalated discs. And remember, both atria contract at the same time. So the mitral and tricuspid valves are open, ventricles fill, and then both ventricles contract, aortic and pulmonic valves are open, and the tricuspid and mitral valves are closed. And when both ventricles contract, well, when the left ventricle contracts specifically, it generates your systemic systolic blood pressure. And then we talked about using the EKG to be able to diagnose heart rhythms and also what's going on in the heart. You can tell the heart attack, angina, you can tell sick sinus syndrome, an old MI. And then the most important thing I want you to take away from this is how a heart attack kills through interfering with the conduction system and taking off with these life-threatening arrhythmias, ventricular tachycardia and ventricular fibrillation. So if you suspect someone is having a heart attack and you're in a place where you can grab a defibrillator until the emergency paramedics come, you can get the defibrillator pads on, you can get everything ready just in case the patient loses consciousness and goes into one of these fatal arrhythmias, you can shock them out of it. And that's the end of this presentation. Thank you so much. And please leave comments, questions, and subscribe to the channel.